will provide a brief introduction to the PROMISE study, which we created for International Clinical Trials Day, which was a couple of months ago in May. And that will just show you a bit more about the project and also the rest of the team who are involved as well. We can.
Black mothers and babies have poorer outcomes than white counterparts. That's a fact.
Did you know Black women are 4 times more likely to face severe health complications during childbirth compared to their white counterparts? Right here, right now in the UK.
As a researcher, every year on May the 20th, we celebrate International Clinical Trials Day. And this is where we honour the power of clinical trials to transform the lives of many people. However, not everybody participates equally in clinical trials. And in the UK, Black women are significantly underrepresented, particularly in maternal and neonatal healthcare research.
The PROMISE study aims to change this by working directly with Black mothers, midwives, researchers and community groups to create clear, culturally sensitive guidelines that help researchers build trust, authentic communication and ensures Black women are fully informed and included.
So if you know anyone who's about to give birth, pregnant, just had a baby or have small children, we want to hear from you.
We want to empower the healthcare staff to have culturally sensitive and appropriate conversations with Black women so they can make informed decisions as to whether they'd like to take part in a research opportunity. It is hoped that by doing so, more women will choose to be involved in this research.
This work is a critical step towards fairer, safer and more effective maternal health care for all families.
Great, thank you for that. Hopefully that provided a sort of brief introduction to PROMISE and the rest of the study team as well. So today we are just going to be presenting preliminary findings. We're still in quite early days of the PROMISE study. It's only started a couple of months ago, so we are right at the beginning. But hopefully, yeah, we can give you a bit of a sort of flavour of where we've got to so far. So I'll give a little bit of background, which I think some of it's sort of come up already with Sue and in Christine's sort of what they've been talking about as well. So PROMISE stands for Principles of Engagement, Developing Methods to Increase Representation of Black Mothers in Maternal and Neonatal Healthcare Research. And this project really came about in response to the inequalities that I'm sure many of us are aware of, which are kind of persistent in maternity care. Particularly the racial inequalities that Black women experience linked to their race and social deprivation. So these are probably statistics that people are well aware of, that, you know, Black women in the UK are 4 times more likely to die in childbirth than a white woman. And that's often linked to pre-existing conditions and also comorbidities, issues around mental health, health injustices that exist in our society. And that inequality also manifests with Black babies as well, who have the highest stillbirth rate in the UK, again linked to other healthcare factors. So we know that this is a big issue. We know this is a pressing issue, and the NHS is trying to tackle these health inequalities and has made this a kind of key area and a mission. But part of thinking about how we address those inequalities is thinking about getting more Black women involved in maternity and neonatal research so that we can understand more about their experiences, more about their bodies, and design interventions which are more personalised and better suited to their needs. So understanding the barriers that they face, and also thinking about the processes at which we recruit women to research. So research delivery teams are often the people kind of on the face of research. For many women, there'll be the midwives or the doctors, the nurses recruiting often, in hospitals or in GP clinics. They're sort of the face of many research studies, particularly clinical trials. And so understanding that relationship and how those staff members can be best supported to recruit Black women to research. And the goal of Promise is kind of to try and think about how we can co-develop guidelines to improve this inclusivity. So the project team is multifaceted. So I'm Dr. Georgia Clancy, I'm the lead researcher, and then I'm based at the University of Nottingham in the clinical trials unit with one of the co-principal investigators, Dr. Sophie Hall. There's also Professor Kathy Henschel, who is a professor of nursing at Oxford Brookes University. And then our co-investigators, Dr. Shireen Patel, who is here as well, also based at Nottingham, and Bhuvan, who is based with Equality Health, who are kind of our community partner, who are helping to connect us with community organizations and make sure that the work that we're producing is really grounded in stakeholder engagement, co-design, and understanding the needs of the communities most affected. So we've got this broader study advisory group, which is made up of different national figures in maternity care, midwives, doctors, people who are specializing in race and equality in healthcare, and also a diverse PPI group. So that's women who have recently given birth or are currently pregnant, also healthcare professionals, and also different community organizations as well. So Black Mamas Birth Village, Black Health Initiative, and Research Black are all supporting the project, again, to support access to those communities and make sure that the work is relevant and practical. So the study aim is thinking about how we can support these research delivery teams. So these people who are on the front line of recruiting women to research and thinking about how they can engage Black women better in maternity and neonatal research in particular. So as I said, this is kind of a timeline of where we are with the project so far. It's just a 12-month project. We are about 4 months in. And so far we have conducted our systematic review, which has been quite an extensive review. I'll say a bit more about it in a minute. So that's looking at the existing literature to try and understand the different cultural, environmental, social factors that Black women face with regards to recruitment and retainment in healthcare research. We are currently in the middle of our focus groups. So we've just recently finished our focus groups with healthcare professionals, mainly research midwives took part in those. And tomorrow we're very excited. We're going to be starting our focus groups with women, and so women who have recently given birth or are currently pregnant. And so we're really excited to start collecting that data as well, and speak to women about their experiences. And then the rest of the project, as we continue to move through it, will be there'll be more PPI because we want this to be a kind of co-developed set of guidelines. So there's an extensive process of PPI meetings and consensus workshops in order for us to develop these guidelines, principles of engagement, which we hope will be really useful for staff members. Oh, super. So the systematic review, as I was saying, we've just recently finished this. We're still working through some of the data, but it was a huge sample of papers. We had nearly 4,000 papers returned when we ran our review search, and through screening and our inclusion exclusion criteria, we've whittled that down to 62 papers, which is still quite a lot of papers, which we've now finished reading and extracting data from. Some of the things that are quite interesting is that the vast majority of that data has come from the US. So we're thinking about this research, we're looking at kind of global patterns, but also thinking about how it will specifically relate to the UK context. And so it's interesting that most of the data is coming from the US, and thinking about that sort of transferability to the UK will be an interesting challenge, I think. So this is a sort of preliminary view of our findings so far. We're kind of currently playing around with different ways of thinking about and presenting this data. And this model here kind of looks at the different contexts and key themes from the review, and how the themes kind of cut across different contexts. So starting at the kind of individual level, which is thinking about beliefs and motivators and barriers. So that can often be like people's personal connection to a condition. That might be a key motivator for them, or not, if they feel that they don't know anything about a particular healthcare condition. They can also often around fears, around taking part in research. Sometimes that can be linked to kind of concerns about exploitation, and particularly, I mean, as Christine was saying, again, because this data is from the US, there's often sort of historical narratives there that people are drawing on because of previous injustices which have occurred in healthcare settings against Black people in particular. Although, as Christine was saying, that's not been as prevalent in the UK, but that's sort of obviously what's coming through in the data, because the data is mainly from the US. And then there's also issues here around healthcare literacy, and also people's sort of research literacy as well, whether research is something they're familiar with and how it works, and thinking about the convenience of taking part as well. And then we can move up into the interpersonal level. So that's thinking about personal relationships between women and healthcare professionals or research delivery teams, whether they have trust in those individuals, whether those teams are diverse, because often what comes through in the data is that people want to see people like them, working in healthcare, working in research teams, to see that there is that commitment to diversity, particularly if people are trying to do research around diversity. And that's often referred to as kind of researcher participant concordance. So thinking about the sort of similarities between the participant and the researcher or the healthcare professional. And also in this interpersonal context is thinking about the support of family and friends and wider communities as well. Often in the data, there's a lot of emphasis on women wanting to discuss their decisions with their community and their friends and family, and needing time to do that. And then we move up into the research operations. So that's thinking about the more kind of practical issues, things about, accessible materials, ethical processes, how the research is designed, if that design is appealing. So, often people are more happy to take part in non-invasive research, things which are more sort of about experiences or behavioral research, rather than taking drugs, having an intervention, some kind of procedure. And also thinking about how research organizations are engaging with communities in really meaningful ways. Often it seems that there's a perception that community engagement can be quite superficial, sort of researchers flying in, taking the data they kind of want and flying out again without really building those relationships, sharing things about themselves with those communities, showing that there is investment, and also really importantly coming back and sharing findings so that those communities feel like they're getting some benefit from the research and aren't just kind of being used as an information source but not ever really seeing the benefits of that. And then the final context is thinking about societal and structural issues. So that can be like the political climate, and sort of wider social issues of trust, kind of institutionally. So it might be linked not just to kind of mistrust of healthcare or research, but mistrust of other institutions like, the police or government. And that can kind of, create a culture of general kind of mistrust, and people live in, maybe what are deemed to be kind of positions of power. And also views around research as being a social good. That's quite a key motivator, often for people, that they want to contribute to research and feel that that's a beneficial thing they can do for sort of all of society, quite an altruistic kind of perspective. But also there can be kind of taboo and stigma around research or particular healthcare conditions that might be being studied, and people's worry about whether they will, whether it's appropriate to share personal information, things about their communities, and also kind of historical issues around mistreatment and systematic racism as well, which as I was sort of talking about with particularly the cases in the US where Black people have been exploited, and those kind of memories have sort of passed down through generations, and then give a sort of a very negative view of research. So I'm going to move on to some of the preliminary findings from our focus groups with research delivery teams. And again, this is sort of thinking about this in those different contextual levels, but also the key themes that are coming out. So this quote, all these quotes are actually from research midwives. So this person said, they're talking about first generation women, and that they don't have that kind of trust in the NHS because they haven't been brought up with it. And so you need to try and build that relationship of trust with them before you start trying to get them to take part in a research study. And this research midwife is just talking a little bit about the process of sharing things about themselves, asking about their baby, trying to have that conversation more casually and build that relationship and trust before you then sort of introduce the idea of research. So I think it's interesting to think about the differences between first generation and second generation women, and how kind of issues of cultural sensitivity and cultural competence for staff might vary when you're interacting with first or second generation women, how familiar they are with the NHS, and how that kind of rolls over into the additional kind of, I suppose, complication of taking part in research. And then also the issue of trust, which is a key theme throughout. In this quote, the midwife is talking about the kind of importance of approaching women of different ethnicities in different ways. So they gave this particular example where they found that white British women would often sign up for studies quite quickly, kind of almost then and there. But Black women were saying they wanted to go away, they wanted to speak to their family, to really think about it, speak to their husband. And the more this research midwife kind of explored this, they found that actually, whilst a white woman was happy to get the information very quickly and consent straight away, with Black women, if they gave them the participant information leaflet and the consent form kind of a couple of weeks in advance, it gave them that time and that space to think about it, discuss it with whoever they needed to, and that led to higher engagement and recruitment levels. So again, it's trying to understand different kind of cultures, and being adaptable and flexible in order to facilitate that cultural sensitivity, and building a protocol, I suppose, around recruitment, which enables that flexibility to take place, and trying to understand the different social factors that might be impacting women's decisions around participation. So this next quote is talking about the translation of literature. And again, I think this is a kind of a theme that Christine covered, which was thinking about, finances and having the budget to translate or to have interpreters on a project who can try and facilitate participation for those for whom English may not be a first language. So this midwife was very aware that there's often limited funding, and if you can't translate the consent form or the participant information sheet, then that counts as someone being having to be excluded because they can't understand that information. And even if there was an interpreter there, or even if there was translated documents, can the research midwife actually then answer the questions without an interpreter as well, to make sure that that woman really fully understands what she's taking part in. And so, you know, language barriers, accessible materials, and the burden that that places on participants in particular, and trying to think about university kind of or research operations in terms of funding, and the ethical questions that that raises around consent. And then this final quote is talking about a specific study, the Devo study. People might be familiar with it. This person was saying that at least half of Black women were declining to take part in this study. And then they spoke to their principal investigator, who was himself African, and he kind of enlightened some of the research team that there were these wider issues of distrust around data sharing because of historical practices and mistreatments around personal information, identities, fingerprints of Black people, and how they've been misused in the past. And that's kind of developed these issues of mistrust. And his interpretation around that this, you know, as a result, Black people were less willing to take part in research because they were more suspicious of what was going to be happening to their data, how it might be used against them, potentially, or for purposes that are not that they're not sort of agreeing to. And so I suppose there's thoughts there around, you know, clear research material, so people understand exactly what their data will and won't be used to, but also trying to build trust that these practices are secure and that they won't be used in ways that they're not supposed to be. But the kind of institutionalized racism and suspicion around that. And again, that often comes more from an American context than a UK context. So I'm just going to finish with some concluding thoughts on our preliminary analysis so far. So preliminary themes from the review are kind of around mistrust, altruism and personal benefit of people taking part, the burdens of participation for individuals, knowledge, awareness, and candidacy, which is about people's feeling that they are suitable candidates for research or for healthcare, and also interpersonal and social influences. And then I've tried to sort of start mapping how this also relates to the themes in the focus groups, which was similar but slightly different, around issues of cultural competency and sensitivity, building trust and utilizing existing relationships, with particularly recruiting, you know, not just always using the research midwife to recruit, but also the midwife or the doctor that woman already has an existing relationship with can be a really great advocate because they've already got that trust and that relationship. And if that person says, oh, you know, should think about this study, then that can often be a great facilitator. And then the flexibility, adaptability, and creativity of research teams to adapt their practices to ways which fit the needs of Black women. And then what came through very strongly in the research delivery teams, focus groups, was a real lack of training or guidance and support to help them do this. There was often kind of general training around equality, diversity, and inclusivity, or cultural competency, that they had sort of generally as part of their jobs as healthcare professionals, but nothing specific to research in particular. And I think that's a real key area which we are hoping to contribute as we carry on with the study. But a lot of overlap between the research so far, and we're looking forward to doing our focus groups soon with women and thinking about how the findings from those will fit in with these findings so far as well. So that's the end of my presentation for now. I just say thank you for listening, and if anyone is interested in getting involved in the study, then we have lots of PPI opportunities for healthcare professionals or for women to be involved in the project and contribute as we go along. But that's all for me for now. Thank you very much.